So if there's no other questions now, we'll move on to Dr. Ben Carey is another one of our emergency medicine physicians. He's also co-director of our simulation center, who will talk to you about airway management in the emergency room and some of the things we've learned from a combination of video review and experience.
Thanks, Rich. This is my email address. I prepared a handout for my presentation. It just has copies of some of the articles that I mentioned and a few other things. If anybody wants that handout, you don't have to take it, but if you want it, that's my email address. Just email me and I'll send it to you. This is a aerial view from our trauma bay here at Cincinnati Children's. From our video system. And to start off my presentation, I want to present a case, but I want to do it with your help. I want you to imagine that you are a part of the ED team working the overnight shift, and you are paged to the trauma bay to evaluate a 7-month-old infant who was brought in by mom for unresponsiveness and recognized in triage due to bruising and overall appearance to potentially have been injured. Mom's story is that the kid rolled off the couch a couple hours before presentation. You respond with the whole team: pediatric resident, respiratory therapists, nurses, trauma surgeons, etc. And in relative short order, recognize that for many reasons the patient needs to be intubated, both for airway protection and because he's not breathing very well. So you ask for medications to be drawn up. You plan to perform rapid sequence intubation or RSI. The pediatric resident is going to perform the first attempt with the anesthesiologist helping. The medications are drawn up. They're brought to the bedside. The equipment's all prepared. You ask the team if we're ready to go, and you start the process. The bedside nurse administers the sedative medication, doesn't say anything, and about 3 minutes later asks if you want to give the paralytic. You say sure. About 20 seconds after the paralytic goes in, the pediatric resident starts the first attempt. The patient is not paralyzed and starts to move, and the first attempt ends. About 45 seconds later, with a bag and mask on the patient, the pediatric resident starts their second attempt. They are not saying a whole lot. You ask them about 30 seconds into the attempt if they can see anything. They say something about the airway being very anterior. About 30 seconds later, so 60 seconds total attempt time, the patient starts to desaturate. When the patient gets to about 80% on the pulse ox, you ask the pediatric resident to pull out. You bag the patient back up to about 100%. The patient is now moving, so you re-administer the RSI medications. That takes about 5 minutes. And talk to the pediatric resident and the anesthesiologist about the next attempt. The anesthesiologist says that they're going to perform the next attempt. The RSI medications are redosed, the bag is pulled away, and the anesthesiologist begins their first attempt, the overall third attempt. It's actually a pediatric emergency or pediatric anesthesiology fellow in their first month of fellowship, and they're pretty nervous because of the environment. So they're struggling a bit, also not saying a lot. About 30 seconds into their attempt, the sats are 80% and falling. About 60 seconds into the attempt, they finally insert the tube. At this point, the sats are 40%, the heart rate is 50, and pulses are lost. Patient is resuscitated after 2 rounds of CPR and 1 dose of epinephrine. You get return of spontaneous circulation. Confirm the tube is in place by exam and chest x-ray, and off they go to the CT scanner. This, although obviously intentionally kind of a worst case scenario, I would argue is not unrepresentative, at least in some of the details, meaning that some of those errors, some of those problems are likely to be present in every case of emergent pediatric airway management, both due to its inherent complexity and the relative inexperience of key team members. the core message of my presentation is that, or my talk, is that mastery of critical procedures should be the standard that we are trying to get to. And mastery even for the most difficult cases. But in pediatrics, where critical procedures like intubation are performed rarely by an individual or by a given team, clinical experience alone is not sufficient to ensure mastery, especially in these uncontrolled episodes of care. Because kids are at greater risk both for failed attempts, specifically with intubation, and complication, we have even greater incentive to try to make our care better. And standardization, for example, through checklist, especially through checklist, is an essential aspect of any effort to achieve mastery with these procedures in our setting. So rapid sequence intubation is defined as the combination of pre-oxygenation, a sedative and neuromuscular blocker or paralytic medication, and intubation. Pre-oxygenation needs to be adequate to allow a safe duration of apnea while you're doing the procedure. The sedative and paralytic need to be given rapidly and in succession, meaning back to back. And intubation should be efficient. Even in the best of situations, these are critically or injured patients, and they have a relatively short window for safe duration of apnea. Although there's not a lot of great evidence supporting RSI, 30+ years of experience throughout pre-hospital setting in critical care and emergency medicine, as well as many observational studies, suggest that it's by far the best way to definitively manage an airway in those settings, and it works for the vast majority of patients. RSI was originally developed to prevent pregnant women from aspirating, and when it became more widespread, it became obvious it was a better way to do it. It was used also for that purpose, including in emergency medicine. In kids, I would argue the primary benefit of RSI is to more safely and rapidly get a definitive airway, and primarily to prevent physiologic deterioration, especially oxyhemoglobin desaturation, which has both its own negative effects on the brain and other organs, and also puts the patient at risk for bradycardia and pulseless arrest, as I described in the scenario. Although efficient care in trauma and medical patients is essential, avoiding preventable physiologic deterioration like desaturation in these patients should be a priority. So this again is our trauma bay here at Cincinnati Children's, and I'm going to use 4 studies that we've published over the last 6 years to describe an overall body of work over the last 8 years, to both study and to improve RSI and RED. I represent a diverse group of people, many of whom are at the table today, and so I'm really presenting work that's been done collaboratively by all types of providers, from the ED, anesthesiology, ICU, trauma services, and many others. There are 3 kind of essential things to understand before I give the details of the study. One is that this is a high volume academic, meaning fellows and residents, lots of them, center with 90,000 plus ED visits a year and 4,000 trauma bay patients a year. We have a video system with cameras in all 4 of our trauma bays. You can see the 2 camera views here. We also have the monitor feed. And we have extensive experience studying airway management. We've now accrued over 400 consecutive cases of RSI in the last 4 years, which is a pretty large number compared to many of the published studies out there. So we first became worried about our performance of RSI about 9 years ago. And this was based primarily on our personal experience, meaning the experience of the investigators. To fully characterize those problems, we completed and then published this study. This study was a video-based study over 12 months of RSI cases in RED. So for 114 patients, over that 12-month period, about 25% were trauma patients and about 75% were medical. The average age was 3. This table presents the adverse effects that we observed in those 114 patients. So among 114 patients, about 60% of patients had at least one adverse effect. 33% or 38 of those patients had desaturation, oxyhemoglobin desaturation, which we defined as the sats dropping to less than 90% during RSI. A lot of people will often say, well, aren't a lot of those episodes brief and minor? Some of them were, but many of them were profound. About half of them were to less than 60%. And had we been able to study it, which we can do now with a monitor view, many of them were prolonged, so longer than a minute or two. Avoidance of desaturation is especially important in critically injured patients, especially those with traumatic brain injury. Hypoxemia and hypotension can both cause their own injury and increase the risk of serious morbidity and mortality in these patients. We found problems, as you can see in the table, all sorts of other adverse effects and problems in the performance of the procedure from stem to stern. So we found problems with medication selection and administration, the performance of pre-oxygenation, and in the confirmatory process. As noted in the editorial response to the publication of this study, these results were likely representative anywhere kids are undergoing RSI emergently. So after demonstrating suboptimal performance of RSI, we were obviously interested in making our performance better. One of the most commonly recommended steps is to make people better at the procedure. And that leads naturally to the question, do we do this enough just in the ED to be good at it? We studied over the same period of time, this was in April 2009 to March of 2010, we studied 12 months of all types of critical procedures in RED, including rapid sequence intubation. This table presents one of the main results of this study. In the left-hand column over here are all the critical procedures that we studied, including orotracheal intubation or intubation. The main finding from this table presents the performance and supervision of our faculty of critical procedures over 12 months. And the main point is very simple, that the median number of procedures performed by our faculty was 0, with 60% of our faculty not performing a single one of these critical procedures. It didn't get any better for number of procedures supervised. The median was 4 overall, 2 for intubation, and 0 for the rest of them. Fellows, the results were the same. A separate table demonstrated that the median number of critical procedures performed was 3. And this obviously, although we didn't report on it, extends to all members of the team, respiratory therapists, nurses, etc. The bottom line is that both for all critical procedures and especially for intubation, clinical experience is exceedingly rare, remembering that we have about 4,000 STS patients a year. Clinical experience is exceedingly rare and far below any reasonable minimum to achieve or maintain mastery just based on experience alone. Having demonstrated that RSI was too rare to rely solely on clinical experience, we sought to identify targets for quality improvement initiative. This study was the third one that we completed, and we performed bivariable and multivariable analysis of the data we collected in the first study to determine factors associated with oxyhemoglobin desaturation. This table, or excuse me, this scatter plot presents the duration of all 200, so each dot is an individual attempt. For the 114 patients, there were 223 attempts. The black dots are desaturation attempts. The open dots are no desaturation attempts. The main things to take away from this figure are that you see desaturation at any duration of laryngoscopy, so anywhere from 5 seconds all the way up to more than a minute and a half. The majority, however, of desaturation attempts are longer than about 30 seconds. About 80% of the desaturation attempts were longer than that duration. The odds of desaturation on any attempt with or by duration were also not linear, meaning they increased, the odds got greater in a nonlinear fashion as the duration got longer. So for a 30-second attempt, the risk of desaturation was 2, and for a 90-second attempt, the risk of desaturation was almost 8. So the summary from the first 3 studies, we have lots of problems with the entire procedure. We don't have enough clinical experience to rely on that alone to get better, and the duration of attempts are especially important in terms of risk of desaturation. So for our fourth study, having characterized the problem and identified key factors associated with important adverse effects, we designed and completed a quality improvement initiative to reduce the frequency of desaturation during RSI in RED. We again collected data by video review, and we developed a bundle of 4 interventions aimed at reducing the frequency of desaturation. The first 2 interventions were the checklist that you see displayed here and the presence of a second pediatric emergency medicine attending in the trauma bay to execute the checklist. The intent of having the second attending present was to reduce the cognitive burden on the physician team leader. I have a copy of this checklist in that handout that I mentioned if you want to see it in more detail. I apologize for its size on the slide. The checklist was designed to address deficiencies in our baseline process that were identified in our original study and that were associated with desaturation. So there are some things that are not on the checklist. It was not meant to be a comprehensive description of the problem. The checklist has 4 main parts: preparation, laryngoscopy, confirmation, and unsuccessful attempts. And key steps include those associated with important duration or important intervals in the procedure. The third intervention was the use of a stored CMAC laryngoscope for all initial attempts, and the fourth intervention was not letting pediatric residents intubate, for lack of a better way to describe that. The inset is a picture of the stored CMAC, and the video that you'll see is a resident performing a laryngoscopy attempt on on a medical patient in our bay. What I want you to notice is that this is what the provider would be seeing while you were in the position of observing. And if you didn't have this video, you would not appreciate both the initial struggle to visualize the airway and, as you'll see, the struggle to get the tube into the larynx. By using the stores is not primarily designed to make the intubator better, although it may do that. The stores is designed to make the team more confident in what the provider is actually performing or actually seeing. So this table presents the main results of our quality improvement initiative and what's happened since the end of it. So the first table are key adverse effects, the first column are key adverse effects, including desaturation, multiple desaturation, desaturation in kids less than 2, and esophageal intubation. During our study, about a third of patients, our initial study in 2009, a third of patients had at least one episode. During the improvement period, which ran from August of 2012 to December of 2013, about 18% of patients desaturated. That has been maintained over the 2.5 years since. You can see similar improvements for multiple desaturation, desaturation in kids less than 2, and the frequency of esophageal intubation. A key reason for the sustained improvement in our performance of RSI is this feedback form which you see here. So we continue since the end of the initiative to review every case, collecting data by video review, and then completing this form and sending it to key providers, including physicians and nurses. Despite our success, there are still major flaws and limitations with our work. First of all, it's single center. Second of all, even though we're using video, we're still missing key aspects of the procedure, especially what people are thinking. Third, and most importantly, we're not at our goal. So our goal when we set out was to minimize desaturation, specifically getting it under 10%. And as you noted, we're not there yet. So in summary, mastery of any critical procedure should be the standard. Nothing less than that should be expected. In pediatrics, critical procedures are performed too rarely by individuals for clinical experience to ensure mastery. Kids are at greater risk of failure and complications, and standardization is essential to mastering critical procedures in our environment. And with that, I'll stop just because of time, and happy to answer any questions.
Great, thanks, Ben. That was great, and it's been a lot of time and a lot of great work. As you were talking, we kind of polled the audience to see who does the intubations at their sites, and most sites seem to say the emergency medicine, although there are one or two that do say anesthesia like we do for traumas. What's your thoughts on this data? Can you share, I know you've looked at it, can you share with the audience differences whether it's an anesthesiologist, a fellow, a resident, or ED physician, and how would that influence, or how does that influence the use of the checklist?
Well, that's a good question. The first you didn't ask it, but the first question I'll answer is that the checklist and the improvement bundle was designed specifically not to address procedural success. So the most obvious solution to this problem is to make people better at intubating, and that's not what we focused on. And we intentionally didn't focus on that because no one really knows, other than making sure that the best anesthesiologist is there every single time, which is obviously not feasible. It certainly isn't feasible for us in an academic center, and it's definitely not feasible at many other places, most other places. So other than doing that, you are ensuring yourself some rate of longer attempts and failed attempts. So we felt pretty strongly that standardizing the procedure with the checklist was the best initial way to make the most rapid improvement in the process. However, we still have a significant gap in our procedural performance. So we did improve. Our initial success rate in our original study was 50%. We're up to about 75%, and we get the tube within 2 attempts for 90% of patients. But we still think that, although we haven't addressed it, making people better at intubating is an essential thing that we need to do. To answer your actual question, one of the reasons that we limited the pediatric residents from intubating, or we eliminated them from intubating, and probably the most important reason, is we felt like concentrating our educational efforts on the ED team and the trauma team would be more effective, and we think that it was. And anytime you add a provider to the core ED team, you're going to increase the risk for for just deviation in how people want to do it. And so we still have a long way to go, I think, in terms of getting not just anesthesiologists, but all sorts of other people who come into the Bay and help take care of patients on the same page.